Hi, everybody. Thank you very much for joining us this afternoon. My name is Libby Graham. I'm a project manager at UCL Partners AHSN, and I'm joined by a couple of colleagues.
Hi, I'm Helen Hoyland from Yorkshire Humber, AHSN.
Hi, and I'm Eleanor Hood. I am from the Royal Free London NHS Foundation Trust, and I am the Principal Innovation Lead there, managing our programme of innovation.
Brilliant. I appreciate there's quite a lot of background noise, so we'll try our hardest to kind of speak as closely into the mic as we can. So we wanted to talk to you today a little bit about a project that we've been doing between UCL Partners and Yorkshire Humber AHSN over the past year, investigating the impacts of AI technology on the NHS workforce. We were fortunate enough to have the opportunity to investigate this topic as part of a wider piece of research orchestrated by Health Education England and involving some other members of the AHSN network. So we're going to talk a little bit about the project, what we did, and then pass over to Ellie to talk about some of her perspectives from the NHS side of things and some implications for industry. So to give a little introduction to the AHSN network, for those of you that aren't aware, we are the innovation arm of the NHS. We operate regionally across England. UCL Partners are based in North Central and North East London. We also cover parts of Essex and Bedfordshire. We have 21 NHS trusts across 6 million, population of 6 million, including 8 higher education institutions. We also host functions that have a kind of wider national and international impact. For example, the NHS Innovation Accelerator, DataCan, and the Genomic Medicine Service Alliance.
And I'm from Yorkshire and Humber, so we're a big population, a big geography. We've got 3 integrated care systems and 19 acute trusts in our patch. And we're working across primary and secondary care, looking at AI and evaluation.
I think that one, how is this microphone doing for everyone?
Wow.
That one's good. Okay. I'll pass over to Helen when she has a go. So I think the first thing that you need to say when you talk about AI is, what do you mean? I think that's the biggest stumbling block. It's so huge, vast, and complex that I think we get lost in the actual definition of what it is and what it does. So an easy way to describe it is the science of making machines do things that otherwise would require intelligence if done by humans. NHSX have put together a useful taxonomy to kind of make that more appropriate within healthcare. They identified 5 different use cases for AI within healthcare. For the purposes of this investigation, we focus on diagnostics and system efficiency within the NHS. So you can see here just a few use cases and examples of how that's used within the NHS. So what were the project aims and deliverables? We've first of all wanted to find out what was out there. So what AI is currently in use within our 2 geographies. Following this, we wanted to do a review of the workforce implications of a few specific case studies of innovation that is in use within our 2 patches. And following that are recommendations for industry and for the NHS on what we need in terms of education and training for AI to be used successfully and safely within the NHS. So we sought to understand the efficiencies associated with the introduction of AI, changes to models of care, changes to workforce roles, arising from these altered care pathways, and then, of course, the associated and training needs. So we initially conducted some insight groups with clinicians, AI experts, workforce experts around the 5 different taxonomies that we saw earlier in the earlier slide. We wanted to just discuss their experiences, their perceptions, their presumptions of AI, their fears. You know, there's lots of things come to mind when you think of AI in healthcare. So we conducted 5 general high-level discussions around AI to build to pull out emerging themes and things to discuss. And using these, we put together a data capture tool, which we would use in the subsequent interviews. We then did a horizon scan of AI technology in use within UCL Partners and Yorkshire Humber's NHS trusts. We shortlisted some innovations and conducted interviews with clinical users, implementation project teams, commissioners and industry representatives, involved in those specific innovations within our NHS partners trusts. Based on the information from that, we put together case studies examining the workforce impact of these AI tech. So what were the selection criteria? You can see we identified 60 projects, 60 initiatives across the two AHSN's patches, but we really needed, in order to investigate the impacts of the AI, we needed something that was in business as usual phase for at least 6 months, ideally a year. The use case had to be diagnostic or system efficiency, as we mentioned before, and we needed those existing relationships with the implementation sites to ensure access to the frontline clinical users of the technology. I'm going to make the two very obvious points here, but these were kind of the big takeaways for us as an AHSN on how do we investigate and how do we learn about AI within healthcare. So the maturity, one thing that came out was that the maturity of AI in healthcare is limited. As we see from the previous slide, from the 60 innovations that we identified within our two patches, there were only 9 that were actually in business as usual phase within these two categories. So we're in very early stages, and most are in pilot phase. The second is the scope of AI in healthcare is very broad and complex, which is, again, a very obvious point to make. But it means that when we're looking at investigating the impacts, we need to make sure we're being more specific. I think investigating AI as an umbrella term is not as useful as investigating innovations in their individual impacts. So these, just to give you an idea of the technologies that we included, they have a range of specialisms across a range of care settings, and a mix between the system efficiencies. You'll probably have seen some of them around this stand as well. They're some of the usual suspects in AI. So as I said, from the insight groups that we did at the beginning, we pulled out some emerging themes, what people were talking about, what interested them, and what they thought would be the main impacts on the workforce. So we pulled out confidence, workload, education and training requirements, and then the skills profile, so any upskilling or de-skilling that would happen as a result of the implementation of the AI. So I'm just going to take you through a couple of the more interesting learnings that we found from these case study impacts. So of course, clinicians must have confidence in the technology to be able to use it effectively. But what we found was they didn't need to know the intricacies and understand the algorithms of how these AI worked in order to have that trust. In terms of roles and workload, we weren't seeing that permanent roles were being removed as a result of implementing AI. We did see that there was less reliance on locum and more expensive agency staff as repetitive administrative tasks were being taken over by the tech. In some cases, workload increased as more disease was detected. So, for example, with iRhythm, because which is a mobile ECG, it's used in the stroke pathway at Barts, and it was picking up more arrhythmias as opposed to the traditional Holter monitor, which actually increased workload. So in some, particularly within diagnostics in primary care, pressures were relieved on secondary care as GPs and healthcare professionals within primary care were taking on more of the diagnostic tasks at the beginning of the pathway, but this was obviously relieving pressures on secondary care. Finally, with terms of education and training, in-person training is overwhelmingly preferred. Training must start with the basics, so there should be no assumptions made about competence. So, for example, with skin analytics, which is a tool used in the dermatology pathway, it involves a smartphone photo having to be taken to determine skin cancer. We found that it wasn't the users didn't necessarily know how to take a good quality image, so they needed training on lighting, distance to skin, and clarity of the photo. And obviously, clinical involvement in the delivery of the training bolsters the confidence in the technology. And finally, in terms of skills profiles, The overwhelming, AI is one of the biggest disruptors to healthcare of our generation. There will be changes to skill sets as a result of it, but it doesn't necessarily have to be a bad thing. It's unlikely that technology will totally usurp clinical professionals, and rather they will be using it as a tool in collaboration. And we found as well, especially in primary care, there was a potential to upskill workers where people were empowered to take on more senior roles in the diagnosing things in the earlier stages. So I'm just going to pass over to my colleague now to talk a little bit.
Is this one working? Yes. So I'm from a commercial team at the AHSN, so we see hundreds of innovators every year, and we work to support them and broker introductions with the NHS where they meet a known need. And traditionally we ask innovators, we get them to think about all of these really important questions here. But what this piece of work I think has reinforced is to think about all of these questions in the context of the impact on the workforce who will be utilising your innovation. So in particular, what staff training and engagement is required, and to think about that right across the pathway, right from the word go. Next slide, please. And so the implications for our work at Yorkshire Humber commercial team, and I think for the rest of the AHSN, is to think about workforce at the centre of an innovation where it meets a need, and consider the impact on the workforce of a new AI technology at each stage of implementation. And so we'll be working to support suppliers and SMEs and AI innovators with implementation guidance to support adoption. And we really need to make sure that we consider the impact on the whole workforce as we do this. And also to consider the complete pathway. So what changes might there be in workflow across the pathway if you're going to introduce a new AI? And very importantly, the forthcoming NICE evidence standards framework around digital and AI. There's a recommendation in there about considering workforce training. So we'll be working with AI suppliers to help them with that in particular. Okay.
So I'd just like to hand over to Ellie, who is a colleague from one of our NHS partner trusts within London, the Royal Free, to talk about her experiences as a principal innovation manager.
Yeah, it's a bit of a mouthful, isn't it? Innovation manager probably works better. So I think what I'd like to speak to first is some learnings that we've had, the implementation on the ground that would be useful for people to sort of take away. So number one, and Libby and Helen spoke to this, is the confidence. So the confidence of the clinicians in the algorithm that you're using, as well as the evidence and the research base, the data set that it's been used on. And that applies to also if it meets, how different it is the demographic of the population that you're serving. So one of the key things to do first is to understand the data sets that's been used, the outcomes that have been presented by any AI product, but also then to test it, to do service evaluation where you are at on your demographic with your equipment to make sure that it works for what you need it to do, because it might not work in your locale. I think the second piece of learning that we've had is in the wider implementation. So you may have a clinician that's really, really intrigued, excited about a particular AI, but you need to onboard your IG lead, your clinical safety lead, your pathway lead onto that journey, and freeing up space and capacity for them to do that. So we've actually brought in a innovation IG lead that supports us across all of these different programs. So that's something else I would say to consider. And I think there's definitely a need for people to buddy up within that. So like DPIAs being the worst word in the world, but how do we start sharing a DPIA about skin analytics that might be helpful for other IG leads to implement? I think the third thing is the maturity of the pathway that you're implementing it on, and also the scale. So if you're looking at an ICS level, you want to implement, say, dermatology AI or a pathway, particularly looking at primary care to secondary care transitions, because that's where there's a lot of efficiency. How consistent is your pathway across your ICS? What are the types of maturity in medical photography? Where is the medical photography being stored? How can it be monitored? And really working out the sort of diagnostic of the pathway that you're wanting to apply it to, and the reality of the pathway that you're wanting to apply it to. I could go on and on and on. But the other thing is if you're looking at something that's embryonic, so as Libby and Helen mentioned, the actual size of the prize in terms of the AIs that can be implemented quite quickly is quite low, and that's because of that evidence base. So there's something about the NHS and the pathways looking to build in the ability to support new AIs coming in. How do we help them with the research and the data that we want them to do, but also make sure we're keeping our health data safe? And that's something that we need to work on, with the academic health science networks, to create that space that enables that. Because it's only through doing researches that you'll be able to get to an AI that you can service, evaluate in your local area, and then you can implement in terms of BAU. But yeah, thank you.